presented by Chris. Well, that was exciting. Dr. Herndon is a professor with the Southern Illinois University Edwardsville School of Pharmacy, and currently he sees chronic pain and opioid use disorder patients within a family medicine residency clinic. He is his interest focuses on pain and palliative care education, and he is the principal investigator for the National Institutes of Health Center for Excellence in Pain Education at SIUE. Dr. Herndon is the 2019 president for the Society of Pain and Palliative Care Pharmacists. He is the 2006 recipient of the Pain Champion Award from the Alliance of State Pain Initiatives. He's also the 2012 recipient of the Academic Pain Educator of the Year Award from the American Society of Pain Educators, and the 2016 Pharmacist of the Year from the Illinois Pharmacists Association, and also the 2018 recipient of the Distinguished Service Award from the American Pain Society. Following this webinar, you will receive an email with a link to a short evaluation. You will need to complete the evaluation in order to claim your credit. This link will be active for 30 days, after which time it will disappear and you will no longer be able to claim your continuing education credits. So get that done as soon as possible. Please put in the chat your institution name, degree, and the CMEs that are needed. And I will now hand it over to Dr. Herndon.
Thank you so much for that kind introduction, and I'm certainly pleased to be here with all of you today. I'm going to try to share my screen. So, okay, so is all you're seeing now my slides?
Yep, it looks good.
Okay, and my video is on, so I think we're good to go. Well, thank you again for joining us. I'm very pleased to be here. I really enjoy talking about this topic, and am grateful for you all taking time out of your busy lunch to share that with us. We have a number of learning objectives we're going to try to cover today. Now, I do need to stipulate that there is a lot of information within this slide deck. And I'm hoping that what we can do is we'll try to get through as much as we can without rushing, but at least if we don't get to the things at the end, I wanted to at least somewhat plant the seed that there are some other opportunities for providing analgesia for some of your patients with chronic pain that may not be readily at the top or the forefront of your thought process when you're making your treatment plan. So one thing that I did want to do is, since we're going to be talking about why some of these various medication classes can be effective, I wanted to provide what I think are the three most outstanding graphics or explanations of what actually is occurring during a nociceptive process or a noxious stimuli. And I think this graphic down at the bottom really summarizes the pharmacology around some of these medications that we're using, where you do have some noxious stimuli or something that should cause pain. And it starts a receptor potential via a number of different receptors. So, you know, we have neurokinin receptors, we have these G protein coupled receptors, serotonin, acid sensing ion channels, et cetera. And once that electrical depolarization starts to occur, it's propagated by sodium channel and potassium movement in and out of the primary afferent that keeps that excitatory potential moving on down the line. And then when we get to the second order neurons in the spinal cord, in order to keep that painful signal moving forward, there's got to be something that jumps over this chasm. And probably the best way to explain that is that you have this glutamate or excitatory neurotransmitter in these little nice packages or vesicles that are released into the synaptic cleft, and then they bind to one of three different glutamate receptors. And these are basically super calcium channels so that we can keep this electrical process moving. And so we can get, that stubbed toe pain all the way from your toe up to your brain. And so the reason that I show this is we have a number of different potential opportunities here to interact with this process. And in fact, your body naturally does this as well in certain circumstances. If you stub your toe, most of us don't continue to have toe pain for years and years and years after we do this. Your body activates the brakes, so to speak, or the descending pain pathways. And what that does, if you can imagine, there's another neuron here or a supporting structure that then can either slow down, turn off, or actually attenuate the strength and the frequency of depolarization. And so we're going to be focusing on some of these different areas and how antidepressants, anticonvulsants, et cetera, may work. So let's start with antidepressants. I try to make this talk as kind of clinical pearl oriented as possible. I know that many of you that are on this webinar already are very, very familiar with most of the drugs that we'll talk about, but if we can put some additional tricks in your hat, I think that will be beneficial for everybody. So when we talk about the use of antidepressants in chronic pain, we have a number of different medications that are available to us. Now, the only ones that are listed on this slide are antidepressants that have specific data in the treatment of various chronic pain conditions. So obviously, when we look to the left, the tricyclic antidepressants, all of them have some amount or level of quality of data to support their use in various pain conditions. The SNRIs that are shown here, like venlafaxine, duloxetine, et cetera, have variable levels of data to support their use. The atypical antidepressants are limited to just bupropion and trazodone as having some limited amount of data. Buproprion's data is in diabetic peripheral neuropathy, and trazodone data in terms of pain is for fibromyalgia. However, the RCT study that was done showing trazodone's benefit was in combination with pregabalin as a synergistic combination. So trazodone alone has not shown analgesic benefit, but with pregabalin, it actually boosts pregabalin's analgesic benefit. Now, over here on the right, the selective serotonin reuptake inhibitors. If anyone on the webinar is old enough to remember when these first came out, there was a lot of excitement around SSRIs and their potential involvement in their use for chronic pain. And unfortunately, all of the studies failed miserably. I mean, they were done, they were just negative, with the exception of these two. Paroxetine has one smaller positive RCT study to support its use in diabetic peripheral neuropathy. And then interestingly, there was a very unusual study published about 2 years ago looking at S-citalopram or Lexapro and comparing it in a non-inferiority study design to duloxetine in radicular low back. And believe it or not, there was no statistical difference between duloxetine, which has very good data in that area, and S-citalopram. So I'm not really sure I would consider these two SSRIs first line, but they do appear to have some supporting evidence. Now, when we talk about tricyclic antidepressants, I know that we have, if you're taking care of patients that are suffering from chronic pain, you know that co-occurring depression and anxiety are, I mean, they're almost a given in most situations. I think the last numbers I saw were somewhere between 80 and 90% co-occurrence. And the thing that I think is important to take home is that tricyclic antidepressants, when we do use them for pain or for migraine prevention, the doses that we typically are looking at are much, much lower than what are actually needed to achieve an antidepressant or anxiolytic effect. And so the killing two birds with one stone with this particular class of medications may not be your best option. But nevertheless, I see quite a few patients referred to us in our chronic pain service that are on tricyclic antidepressants for some type of chronic pain syndrome, and they're getting fairly decent effect size from these medications, but they're having difficulty tolerating the adverse effects with these. And so one of the interesting things with this, when you look at the antihistaminergic effects of these medications, so basically how much do they look like Benadryl or diphenhydramine, and how sleepy and dry mouth and et cetera are they going to cause? I've listed the antidepressants in this class in order of how much they impact the histaminergic system. So doxepin, for instance, which is FDA approved for insomnia, has the highest amount of sedation, dry mouth, the things that you would expect to see with a antihistaminergic effect. And then as you move down, you see lower and lower and lower. That actually, as we start to get down to nortriptyline and desipramine, you actually start to see clinically relevant differences, not only in studies, but I've also seen this anecdotally in my practice as well. So if somebody is referred on amitriptyline and they're getting a benefit, but they're hungover, they feel like they're hungover the next day or overly tired, we will switch them to either nortriptyline or desipramine and usually have pretty good success. Now, one of the things, I think most of you are very familiar with tricyclic antidepressants. I just want to make sure everybody is also aware of some of the risks. Everyone is, I think, very confident in the knowledge that tricyclic antidepressants do have cardiovascular risk with them. I tend to avoid these drugs or this drug class in anybody who has pre-existing cardiac arrhythmia history, heart failure with reduced ejection fraction, and anybody with a really significant prior history of any cause cardiovascular disease. The thing that kind of changed my mind about this drug class was a meta-analysis that was published some years ago that looked at the incidence of sudden cardiac death when we start to get up to actual antidepressant doses of tricyclic antidepressants. I don't think that it's necessarily relevant in the doses we usually use below 100 milligrams, but they weren't really necessarily able to tie that completely to the arrhythmogenic effects of these medications, or i.e. the QT prolongation. The other thing I'm not really sure about is there are some recommendations out there from the Psychiatry Association recommending baseline EKG in patients that you're going to initiate on a tricyclic antidepressant over the age of 50 years. There are also some consensus groups that have come out with a statement of over 40 years. But what's not clear is that for those of us who are using this for pain, or is this for people who are using them in the higher doses for psychiatric effect? The other issue that we need to discuss is the difference between secondary and tertiary amines. Tertiary amine tricyclics tend to be much more lipophilic and able to cross into the CNS better than the more polar secondary amines. And for our purposes, the two tricyclic antidepressants that are primarily clinically used and readily available and inexpensive that are secondary amines, or the ones that are going to have less antimuscarinic effect, are going to be nortriptyline and desipramine. So obviously the ones that you saw towards the bottom of that list on that graph. And then obviously sedation and even some other mental status changes come with the antihistaminergic effects. And we tend to see lower amounts of that with desipramine and nortriptyline as well. There's a few behavioral health risks with these medications. They can cause a withdrawal syndrome that you need to be aware of. Certainly, I would say most of you are aware of the potential for rebound depression if these medications are abruptly stopped. And potentially most concerning, at least based on some of the literature that I've reviewed, is the risk of inducing a switch in an undiagnosed patient with bipolar disorder. So if somebody's presenting with depression and pain, and you initiate one of these medications for pain, there is a small but real risk that you can bump them into a manic or hypomanic episode. I probably don't really need to talk about serotonin syndrome, but I think it's important to bring that up as we're using antidepressants in the context of chronic pain. I see quite a few patients that get referred on both tricyclic antidepressants and medications like duloxetine or venlafaxine that heightens that risk of serotonin syndrome. I know we probably are all overly cautious about this particular manifestation of using too many serotonergic drugs, but if you've ever seen it and discussed it with a patient who's experienced it, it's definitely worth our healthy respect, so to speak. The other thing that I think is important to note, or at least to remind everybody, everybody is comfortable that tricyclic antidepressants can cause cardiac conduction abnormalities, specifically QTc prolongation. However, two of the medications that are in the SSRI class or SNRI class that need to have a healthy respect for in terms of their EKG changes are citalopram or Celexa and escitalopram. And then not listed on here, but getting more and more information around it is venlafaxine and its potential QT prolongation effects. So again, it's just a matter of we have I think a limited number of tools in our toolbox for these folks. And so we want to make very certain that we're picking the right adjuvant analgesics based on other comorbid conditions. Another one that we've started to see a lot more frequently with this class of medications, specifically the SNRIs and SSRIs, is hyponatremia. Some literature suggests that the incidence can be as high as a third of patients that are exposed to higher doses of these medications, and it's usually early on in the initiation of treatment. There are certainly conditions that predispose individuals to hyponatremia. One combination that I see quite frequently are a carbamazepine or oxcarbazepine as adjuvant analgesics, and then add on an SNRI, and it compounds the risk for hyponatremia. We typically in our clinic will try to get follow-up labs relatively soon after, and then we educate our patients on the signs and symptoms of what hyponatremia may look like, so that they can let us know even before their follow-up if they start having issues there. Another poorly understood but very real issue to consider, specifically with these two medications, SSRI and SNRI, is the potential for bleeding risk. Now, these two medication classes by themselves do not appear to increase bleeding times or increase the risk of gastrointestinal bleeding. However, when you add one of these medications onto a platelet active medication such as an NSAID, that risk for GI bleed does go up significantly, and that's been fairly well now described in the literature. So we really need to make sure that we're thinking about that and thinking about risks for GI bleed with NSAIDs by themselves, and then how much, and adding a medication like venlafaxine, duloxetine, or milnacipran on board may increase that risk. So just something to think about. Kitty, I want to make sure that I'm not missing any questions. Is somebody monitoring the question?
Yes, we are. Yes,
Okay.
we're fine.
Please interrupt me. I would always rather have healthy dialogue than talking slides. I know that can be pretty brutal, especially halfway through your day.
Yes, I'll let you know if anyone has any questions. And so just place the questions in the chat if you have any questions.
Okay, thank you so much. So what I'd like to do here is I'd like to throw up onto the screen all of the different commercially available anticonvulsants that are in the US, and talk a little bit about where they may have a role in chronic pain management. So if we run down the first generation anticonvulsants, and this is basically which of these medications has positive data, preferably double-blind, placebo-controlled, randomized studies, but which of these have data in the treatment of one or more chronic pain conditions. Obviously, carbamazepine has a wealth of information behind its use. Phenytoin, believe it or not, has data in diabetic peripheral neuropathy. I'm not sure I would recommend that, but it does have data. And then valproic acid also has data in both DPN as well as post-herpetic neuralgia. Again, it may not be a great first-line go-to medication, but just know that that is a potential tool. If we jump over to the second and third generation anticonvulsants and we start rolling through which of these medications has positive data and could be considered as an adjuvant analgesic, we have first off gabapentin, which everybody is familiar with, lacosamide or Vimpat, which is a little expensive. I've maybe been able to use this in 3 or 4 patients. And the data is equivocal. So there are positive studies in DPN as well as in radicular low back pain. However, there are also some negative studies as well. So that's something to keep in mind. Lamotrigine tends to have the bulk of its positive data in the areas of HIV neuropathy, which we really don't see anymore, at least in my service, probably because of the ramp up of some of these amazing new antivirals. But where we do also still see its use is in not only pain associated with spinal cord injury, and it tends to have a fairly good effect there, as well as in pain associated with MS. Levetiracetam, or then there's another new version of levetiracetam called breviracetam, but levetiracetam has positive data in painful small fiber neuropathy, and it has some less high quality data to support its use, but has been shown anecdotally as well in our practice to be effective for patients with some kind of unusual phenotypes of fibromyalgia. So, and I don't want to get into too much of the weeds in terms of is it fibromyalgia or is it small fiber neuropathy, but for those of you who work with chronic pain patients, often patients with fibromyalgia will sometimes describe burning in their hands that could be SFN, but has not been technically diagnosed, and those patients tend to respond well. Oxcarbazepine is, I would say, kind of like the nicer and less offensive sibling to carbamazepine. It has good data in several of the neuropathic pain conditions. Unfortunately, a lot of the guidelines have picked up on some of the negative and less well-designed studies and have kind of moved it to further down on the list. We still will use this in patients who have failed more traditional anticonvulsants like pregabalin, gabapentin, et cetera. Moving on down, obviously everybody is very familiar with pregabalin. One quick clinical pearl with pregabalin that a lot of people I don't think realize is that while gabapentin and pregabalin actually have the exact same mechanism of action, they bind, if you'll remember the little picture I showed you, they bind at the very end of the presynaptic cleft and then in turn reduce the amount of glutamate that's actually being released, but technically they're a type of calcium channel blocker. But a lot of people think if you fail gabapentin, that pregabalin will not be effective. And that myth has actually been dispelled in research studies. And in fact, what we see in clinical practice is that a lot of patients will develop like a tolerance or a tachyphylaxis to gabapentin. And now that pregabalin is a little bit more widely available from a payer standpoint, we can move them over to that particular medication. Now, something that's been coming up quite often lately is the abuse potential of these two medications. And I think it's definitely something that needs to be considered. It's a very real phenomena. However, we also need to be taking into consideration the relative abuse potential between the gabapentinoids and potentially an opioid or a benzodiazepine. So while they do have abuse potential and they have shown to have some misuse and some street value, definitely not at the caliber of a lot of our opioid analgesics. One last group of medications that I want to talk about here that we've had pretty good success with are topiramate and zonisamide. Now, most of you are probably familiar with topiramate and its use in migraine prevention. It does also have data in diabetic peripheral neuropathy and radicular low back pain. And if you know topiramate, you then know it's less potent, more readily tolerable little sibling zonisamide. They're almost structurally the same. They have almost the exact same mechanism of action. And so a lot of times when patients have been unable to tolerate topiramate, we'll switch them over to zonisamide, and that allows us to titrate the drug slower, and the patient tends to have a little bit more tolerability with it. So these are the mechanisms of action for our first generation anticonvulsants. The reason I think it's important, even though it's kind of nerdy pharmacy stuff, is that if you remember that picture that I showed you on the first or second slide, there were a number of different areas that we could hit to try to slow down the electrical signal. And I get a lot of pushback from patients when I'm talking about, we'd like to put you on this medication or that medication. And they're like, well, you know, I got to the pharmacy and it said this was for epilepsy, that it's anticonvulsant. And then, to try to, I guess, talk through that and educate the patient before it gets to that point. The way that I explain this is that, your nerves that conduct pain are very similar to a cord that's plugged into the wall and going to a lamp or a light. And where, ideally we'd want to be able to flip the switch on and off to turn, the light or the pain on or off. In most situations, that's not feasible. And so really what these particular medications like duloxetine and the anticonvulsants do is they act more like a dimmer switch, and they reduce the intensity of the light and slow the speed of the electricity down, but they don't completely get rid of it. But you'll notice that almost all of these medications that have positive data in pain are voltage sensitive sodium channel antagonists. There also is some GABA activity with valproic acid. And remember, GABA is an inhibitory neurotransmitter. And then you'll notice we also have some calcium channel antagonism here as well. When we look at the newer medications, we start to see a little bit more variability in what they actually do. You will notice that the voltage sensitive sodium channel activity is pretty common throughout. There is one or two medications that have potassium. Notice this NMDA activity and AMPA activity here, as well as with topiramate and zonisamide, GABA activity, alpha-2 delta calcium channel activity, and then carbonic anhydrase inhibition activity. And the reason that I bring this up is that it is not uncommon that we may need to use more than one type of anticonvulsant to adequately address a patient's chronic pain. And so there's such a thing of irrational and rational polypharmacy. For example, if I were going to use multiple anticonvulsants to try to help a patient with pain, very unlikely that I would use oxcarbazepine, which is solely a sodium channel drug, and lamotrigine, which is solely a sodium channel drug. But I'd feel very comfortable using, say, oxcarbazepine, which is sodium channel, and a gabapentinoid, which is a calcium channel drug, because there's no overlap in mechanism of action. And you'll notice that, you know, if you are actively referring patients to specialty pain clinics, you'll see this occur quite a bit. There's not great data to support this practice where, you know, these two drugs together work better than these two drugs together. A lot of this, unfortunately, is just anecdotal experience, but I think it's important to at least share some of that clinical experience.
We do have a question. This is from Erin Nolan. And Erin asks, what diagnosis is used when prescribing these medications for pain management?
Well, thank you, Erin. I think that's a great question. And really, it depends. And I know that's not a great answer. Good question, terrible answer. It really will depend. I try to be as specific as I can in my particular diagnosis that I use. You know, one of the things, we're a residency training program for family physicians, and one of the things that we really try to harp on is don't use the diagnosis pain syndrome or chronic pain syndrome. Try to be as specific as you can and use that as your diagnosis. You'll find, since the opioid epidemic has really kind of taken full speed and has become a lot more front and center with a lot of our third-party payers, particularly Illinois State Medicaid, that the specific diagnosis that you use to try to prescribe some of these medications is does not result in outward rejection of the claim as frequently as it did, 5-10 years ago. So I'm not sure if that's what you're looking for, but if you're treating fibromyalgia, use the diagnosis fibromyalgia. Don't put it under chronic pain syndrome and then describe it as fibromyalgia. I think you got to do your very best. And if you're not absolutely sure, do your best and use a little bit more vague code. But the more specific you can be, the better off it's going to be as you start to try to dive into the evidence of, does this work for fibromyalgia or just neuropathy, right? And I think that that'll be very helpful too as you either transition patients to other providers or refer them out. The other thing that I wanted to share with you all is that there is a lot of interest in the pain research community around this particular class of medications. And as you can see, there's a ton of different stages of research that are going on with even the older medications. If you get on clinicaltrials.gov, you'll still see ongoing pain studies with carbamazepine. There's a few with ethosuximide, which we very rarely see used anymore outside of some of the pediatric epilepsies. We have level 2, which are randomized controlled trials for valproic acid and fosphenytoin and phenytoin. So it's not a bad idea that if you're running out of options, go to the primary literature or clinicaltrials.gov, because at least it gives you some level of evidence-based support to what you're trying to do. With the newer medicines, I mean, they're all of interest, basically. I think that probably the one that is the most interest of mine personally, that I really haven't seen any results on yet, is this particular anticonvulsant perampanel. And if you'll recall, that's a specific AMPA glutamate channel antagonist. And I think that once results start coming out around this one, it's going to be a very interesting potential option, especially in the prevention of transition from acute to chronic pain. You'll notice also that topiramate and zonisamide still have ongoing interest in their use in a number of different pain syndromes. Both of these medications do have some downsides. There can be some neurocognitive dulling, word finding difficulties. A lot of patients will describe paresthesias or tinglies. And because they are carbonic anhydrase inhibitors, you do have to worry about nephrolithiasis or kidney stones with these drugs, and potentially metabolic acidosis. So, if a patient has had a previous history of kidney stones or acid-base abnormalities, I tend to be a little bit more cautious trialing one of these medications. But otherwise, we use them fairly frequently in our service for, well, obviously migraine prevention, but we also have used them for small fiber neuropathy, fibromyalgia, and probably most frequently radicular low back pain, chronic radicular low back pain. There is a black box warning across the class of anticonvulsants around suicidality. It's unclear if this is due to the drug or due to the fact that most of these drugs came to market as treatment for epilepsy, and there is a higher than baseline risk of suicidal ideation in patients with epilepsy disorders than the general population. So it's really unclear how worrisome this actually is. I personally clinically have not seen this. I do get very scared about the dermatologic reactions with a number of these anticonvulsants. If you've ever seen SJS, you don't ever want to see it again. And potentially worse is toxic epidermal necrolysis, or TENS, and this is basically like SJS, but more widely distributed. And then there's another drug-related dermatologic reaction that a lot of people haven't heard of called DRESS, or drug rash with eosinophilia and systemic symptoms. And that one has been described with both carbamazepine and oxcarbazepine. And really where this all boils down to is the chemical structure of the individual anticonvulsant. The bulk of the dermatologic reactions, including SJS and TENS, tend to be in medications that have this aromatic, these aromatic rings here. And what you will see typically is that if it's going to happen, it will happen within the first month or two of initiation of therapy. The most common that you'll see this in is in carbamazepine, oxcarbazepine, and lamotrigine. Now, the lamotrigine risk of SJS has gone down substantially since they've identified that it's more frequently seen in children, and that they've lengthened the titration schedule where we bump the dose up every 2 weeks instead of every 1 week, and the rate of SJS went down significantly with lamotrigine. There are some pharmacogenomic monitoring recommendations if you are going to start carbamazepine specifically in a patient of Asian descent, and this is this HLA-B 1502, and that is predictive of developing one of these really bad dermatologic reactions. Now, when we start oxcarb or carbamazepine in one of our pain patients, we will tell them, and this is a very important, not only documentation standpoint, but patient education, is if you develop any kind of rash at all, stop, don't take the medication any longer, and let us know immediately, okay? If you can't get a hold of us and the rash doesn't appear to be improving at all, you need to go to the emergency room. We get really worried about SJS with these drugs. I have seen it only with carbamazepine personally, but I think the risk is serious enough that it's important to have a very healthy respect for that. The other thing that all of these medications have that most people only attribute to topiramate is this neurocognitive Dolling. There you can see psychomotor reaction time decreases, changes in learning, memory, executive function. The biggest one we see in practice is with topiramate and word finding, but you can see it with the gabapentinoids as well. And so it's important that we're asking patients how they're doing on these medicines, especially as we're increasing the doses up to moderate to highest of the doses. Okay, so I'm going to catch my breath and take a quick drink. I think we're doing okay on time. And if there are any questions about either antidepressants or anticonvulsants and their use in pain, please throw them in the chat. And we will move on to the non-steroidal anti-inflammatory drugs. Now, basically, we've kind of lumped all of these different classes of medications that we've talked about that we can use in chronic pain into non-opioid analgesics. And I'm not sure I'm really a huge fan of that taxonomy or terminology, because some of these medications aren't necessarily analgesic on their own. And so, we used to use the terms adjuvant analgesics, and then the IASP recommended we use the term co-analgesics for those that we add onto other medications to get a more beneficial response. However, NSAIDs are actual analgesics on their own right, and there are a host of different NSAIDs that are commercially available to you to use. And what I would like this audience to think about is while all of these medications that you see on the screen are indeed considered NSAIDs, I'd like for you all to think about them in 5 different buckets or subgroups of NSAIDs, because their chemical structure is so different that failing one in one class may not necessarily mean that you throw out all the rest of them in the other classes. And we see this quite a bit in our practice. I know that all of you on the webinar likely have your favorites. Your patients have their favorites. Certainly the over-the-counter medications like ibuprofen and naproxen, which are both propionic acids. I hear all the time, hey, let's maybe try an NSAID and see how that helps you out. And no, I've tried both ibuprofen and naproxen. Neither one of them worked. Neither of them helped, or I wasn't able to tolerate either of them. And by going down this path of, well, maybe we look at a medication in one of the other subclasses, oftentimes we can maybe see efficacy or tolerability differences when we move between these chemical classes. Now, a couple quick clinical pearls around some of these meds. Well, I tell you what, let me wait for just a minute before I get into that, and we'll keep moving. I believe now that every one of these medications is generic. And when I looked at the Illinois Medicaid formulary yesterday, I was pleasantly surprised at how many of these NSAIDs are actually covered as preferred analgesics in the most updated Illinois Medicaid formulary. So, I mean, we have a lot more tools than we typically think of that we can use. Now, I asked you to consider the NSAIDs in terms of what box of chemical class they fall into. The next way that I would like for you to think about these particular medications is in their COX-1 to COX-2 selectivity ratio. And so obviously the more COX-2 selective a drug is, the less GI effects, the less bleeding. However, theoretically, the more cardiovascular risk that a patient might be taking on. Without getting into a really long history lesson, many of you probably miss greatly and remember Vioxx or rofecoxib, which was removed from the market now quite a few years ago, that basically led us to further research and try to understand the cardiovascular impact of these NSAIDs. And as we move down, a lot of my colleagues are under the impression that celecoxib is the only COX-2 selective NSAID left on the market. And when in fact, we still have Atodolac, diclofenac, and meloxicam, which have similar COX-2, COX-1 selectivity ratios. Now, the theory around this is going to be these medications are going to be a little bit safer on the gastrointestinal tract, but potentially may have a little bit higher cardiovascular risk. That has not teased out really, really well in large outcome studies, with the exception of celecoxib. Okay. And so, we're basically trying to apply, the best of our ability, the pharmacology of these drugs with clinical outcomes. Now, the other thing that I want to make sure that you're aware of is that we've been researching NSAIDs and cardiovascular risk for probably 15 years now. And what I would always tell prescribers and students is, based on the overwhelming body of data that is out there taken together, it appears that naproxen and then probably shortly thereafter ibuprofen are probably the two safest NSAIDs in terms of cardiovascular risk. So if I'm otherwise healthy, I get put on an NSAID and then I have a fatal or non-fatal MI, which ones are more likely to lead to that? But we didn't really know for sure. I mean, we knew it with rofecoxib, we knew it with valdecoxib, and we thought we knew it with celecoxib. However, naproxen and ibuprofen appear to be relatively middle of the road in terms of risk. Diclofenac, oral systemic diclofenac, appears to have the highest risk of any of the NSAIDs on the market in terms of cardiovascular risk. And in fact, if I'm referred a patient who's on diclofenac, I will actually try to transition them to a different NSAID because I feel the data is that compelling. Now, the one that's questionable now is there was a study published about 2 years ago in New England Journal comparing naproxen, ibuprofen, and celecoxib. And, without getting into a journal club discussion, there are some limitations to that study. But basically what it did was it led us to believe that potentially celecoxib was not as risky from a cardiovascular standpoint as we originally thought. In fact, it appeared to be relatively equal, or maybe even a hair safer than naproxen and ibuprofen based on that particular prospective study. I guess my big take home from this is diclofenac is probably not a great choice systemically unless you've burned through all of your bridges and you've really thought about the risks associated. This is a little easier way to—
I have another question.
Yes.
Is this a good time?
Sure.
Okay, this is from Elena Rickard. Methadone patients with OUD and chronic pain have difficulty tapering off of the medication due to the pain returning with dosage decreases. Do you have recommendations for medications for methadone patients while tapering and after tapering? Clients have reported being treated as drug seeking by pain clinics, and many stay on methadone at doses under 30 milligrams due to pain issues.
That's so, as we're potentially, what I may need to do is give that some thought as we're weaning opioids, methadone as well. We do seem to really see some elevated hyperalgesia even above their baseline normal pain. The short answer is that we frequently, if we are weaning patients, we will frequently empirically initiate a long-acting NSAID to try to help them with that. So it not only helps potentially with some of the underlying pain that may have led to the initial initiation of opioids in those patients to begin with, and then the myalgias and arthralgias that they frequently will describe as we're either weaning prescription opioids. I don't wean methadone. We'll use it for pain, but I don't have any experience with weaning it as a medication for opioid use disorder. But I have a lot of experience weaning buprenorphine, and we'll see quite a bit of myalgia and arthralgia in those patients, and they tend to respond fairly well to the longer acting NSAIDs of whichever choice you have. If that did not answer your question, please drop it in the chat and I'll try to clarify a little bit more as we kind of round the corner here. This is just another way to look at the cyclooxygenase activity of the different NSAIDs, and we tend to think about which medication we want to put patients on based on where's their risk at. And I think it was the American Gastroenterology Association that did a really nice job of kind of putting this together, and I have that for you here in a second. One of the big important pieces of this is obviously NSAIDs are responsible for, I think, something like 14 to 16,000 upper GI bleeds, documented GI bleeds a year. That's obviously a big deal. Cardiovascular risk with NSAIDs are obviously a big deal. But where I think we tend to maybe lose some of the steam in terms of what we know about these medications is their impact on renal function and their potential renal or nephrotoxicity. And so if you think of the more COX-2 the selective, or more COX-2 selective the drug, the more cardiovascular risk, the more COX-1, more gastrointestinal or bleed risk. But renal impact of these drugs it's an equal opportunity offender. It doesn't care what the cyclooxygenase selectivity is. It's the same from COX-2 all the way down to COX-1. So when we talk about the risk of bleeding from NSAIDs, for those of you who are ancient like I am, you probably remember being taught that NSAIDs were acids and they sat on your stomach and they caused ulcers and bleeding. And so if we enteric coat them or buffer them, we see less of a risk there. What we now know is that this is a prostaglandin mediated impact. And so really the buffering and the enteric coating and the taking with food and all of that does not reduce the risk at all of a GI bleed from an NSAID. All it does is maybe reduce the dyspepsia or the kind of the nasty, yucky, sour stomach feel from that. So it's really a systemic impact versus a direct localized impact. These are the risks, and I think this is probably one of the better, I think this is probably one of the better studies that have been done looking at the risk of GI bleeds. And you'll notice obviously that there is an increasing risk with GI bleed as we kind of go down that figure, growing closer to COX-1 selective with medications like indomethacin and ketorolac. Now, I don't know if any of you do this in your practices. We have quite a few patients with chronic pain that will go through flares where they feel like they need to go to the emergency department. Their normal regimens are not controlling them. And one of the things that we've done for quite a few of these patients who are more frequent guests in our emergency department is we've started allowing them to come in no more than once or twice a month for a nurse-only visit, and we'll put in an order for a 10 to 15 milligram intramuscular injection of ketorolac in our clinic versus having them go to the ER. And I think that that has resulted in a lot better patient satisfaction and I'm assuming a lot lower costs to the health system and to the patient as well. There are some risk factors with NSAIDs, NSAID-induced GI bleed that are listed here. I think most of them are intuitive. Don't forget that the SSRI-SNRI combination, while it hasn't been officially added, probably needs to be. And there's a lot of discussion right now whether we should be looking at H. pylori before initiating long-term NSAID use. If you are concerned, proton pump inhibitors and misoprostol will prevent GI bleeds from NSAIDs, and that's been shown in really robust studies. H2 antagonists like famotidine will not in typically prescribed doses. Renal function is an impact. What we see basically with NSAIDs and renal function is that unless you already have pre-existing renal dysfunction, NSAIDs don't tend to really impact your renal function that significantly. Now, once you start to see a decline, that's when NSAIDs can really wreak havoc, especially if you have a patient on concurrent ACE inhibitor therapy. And the way that NSAIDs can cause renal nephrotoxicity is kind of twofold. One is a direct nephrotoxic effect to the tubule, and the other one, and the one that's more profound, is the hemodynamic changes that are seen when you give an NSAID, you inhibit prostaglandin, and you basically are choking off blood flow to the glomerulus, which decreases glomerular pressure, decreases filtration, increases blood pressure, and stimulates the RAS system. NSAIDs from a cardiovascular risk standpoint, like I said, the AHA came out with a somewhat dated but very thorough review. And basically what they said is that if you absolutely have to put somebody on an NSAID that has established cardiovascular disease, they recommend that you go with a non-acetylated salicylate first. Now, I probably am going to have to back up a little bit just because these are ancient drugs, but these are your non-acetylated salicylates. Diflunisal, which is on the Medicaid formulary, salicylate, which also I believe is on the Medicaid formulary, and choline magnesium trisalicylate. And I do not believe that is on the Medicaid formulary. So these were drugs that are very, very, very weak cyclooxygenase inhibitors. They tend not to be preferential for one or the other, but they really just are not potent enough to really demonstrate significant antiplatelet effects. Sorry, I'm jumping around. Don't forget, we have a number of topical NSAIDs. I'm sure everybody's familiar with the diclofenac gel. Don't forget, we have a patch available to us and a sodium or a diclofenac sodium like liquid pump that's a little higher percentage. If you are in a rural health center or an FQHC, don't forget about your 340B program. The Flector and the Pincet are both very affordable for your patients if you are practicing out of one of those centers. And basically, this is to show you the relative difference between the blood concentrations of an oral diclofenac tablet and how little we actually see with these topical formulations. However, even though we're getting very little systemic effect, you can see here based on osteoarthritis of the knee that topical diclofenac and oral diclofenac do not separate in any of the three primary outcomes measured with osteoarthritis. So this is, I think, the take-home, balancing GI and CV risk with NSAIDs. If you don't have access to this article, at least screenshot the little figure up here. I think it's very nice, and it really gives you a place to start when you're trying to balance which NSAID you're going to actually start with. I'm getting short on time, but I do want to cover the skeletal muscle relaxants. The basic take home on these drugs is there's very little data to support their use long term. Many of you probably would agree that we're not really sure whether they're true analgesics or adjuvants versus something to help patients with chronic pain sleep at night. Now, I do have some caveats to that. When you look at them, if we split them into spasmolytics and antispasmodics, there are some very distinct differences in actually the mechanism of these drugs. And what you'll tend to find is a lot of the tried and true chronic pain providers really tend to like baclofen and tizanidine. Some of these other medications over under the antispasmodic section, hopefully most of us are steering clear of carisoprodol. I see a lot of patients come in on cyclobenzaprine, and if they like it, I don't change it, but I very rarely will start cyclobenzaprine. With the exception of fibromyalgia. It does have level 8, long-term level 8 data, dosed 10 in the morning and 20 at bedtime for fibromyalgia patients with very good outcomes. Another one that's overlooked that is commonly covered by insurance is orphanedrine. It has NMDA and sodium channel antagonism. I also want to just leave you with some clinical pros around baclofen and tizanidine. A lot of the patients that I work with really seem to respond well to baclofen. if you are going to push the dose up high to like the 60, 80 milligram range, you really have to counsel the patients not to abruptly stop it. There is a fairly serious withdrawal syndrome that can occur that includes seizures, but also some other potential mental health issues. And then tizanidine, if you will remember, is an alpha-2 agonist, just like clonidine. So you're going to see some blood pressure drop. And if they abruptly discontinue this medication, you can also see rebound hypertension. So I'll go ahead and stop there. But if the slides are available to you all, I also put a lot of information in here around the use of medical cannabis for pain, medications that have specific NMDA antagonism, which is thought to be what drives hyperalgesia and chronification of pain. And then last but not least, I put 1 or 2 slides in here around the use of something called ultra low dose naltrexone. Yes, naltrexone is an opioid antagonist. However, we are starting to see some very interesting data come out in terms of its efficacy for fibromyalgia, for pain associated with inflammatory bowel disease. And we are actually just getting ready to launch a study looking at ultra low dose naltrexone in chronic non-specific low back pain. So with that, I'll stop and I will hand it back over to our wonderful conference organizers.
All right, thank you very much. That was a wonderful presentation. Now, Dr. Herndon, if you could make me the host again.
I feel like I have so much power.
You do have a lot of power. I have a PowerPoint slide that I'm going to share, and let's see.
Did that work?
Yes, that worked. And I am going to share this. Do you see the PowerPoint slide?
No.
Great. Okay. Let's see. Let me see now. It has a link on it, and we have a QR code that you can use to claim your credit. Do you see that?
We see the slide deck. Oh, there it is.
Okay. Okay. So if you point your telephone camera at this QR code, it will enable you to claim your CEUs. And let's see, I guess that, let's see, I want to keep it at that one. There we go. I'll just do it this way. And you'll have to do this within 30 days. So also, if you haven't done so already, if you want CEUs, could you please type in the chat the institution name, that's where you work, your degree, and the CMEs that you are needing. So I want to thank you everyone for joining us, and especially thank you to Dr. Herndon. This was a wonderful presentation, and this will be available on the SIU School of Medicine website. If you would like a copy, just email me at kjuul31@siumed.edu. So thank you again, everyone.